Good morning, everybody, and thank you and welcome to another vertical integration. Very happy to see everybody this morning. Today we've got Dr. Ebony Tosh, who's going to be talking about medical termination in pregnancy and general practice. Thank you, Ebony. We're really grateful to have you here. Just a couple of things to let you know. I'm Sandy Vincent from the PHN Education team. I would like to start by acknowledging the traditional custodians of the lands that we all live and work on. I'm in beautiful Darkinjung land this morning, and I would like to pay respects to elders past, present, and thank them for the wisdom that they impart to all of us. This session is being recorded. At the end of the session, I'm going to put a link in for an evaluation. As always, we're very grateful for those evaluations. Thank you for that. And I'll also be adding in a health pathways slide. But I would like to hand over to Ebony. Ebony, thank you if you'd like to put your slides up.
Yeah, let me. Has that worked?
Yes, that is beautiful. Thank you.
Okay, perfect. All right, so topic for today is medical termination of pregnancy in general practice, which is something that I do quite a lot of, usually at least one a day, and have been practicing in this space since 2018. Learning outcomes for today. So I want everyone to kind of understand a little bit more about what medical termination of pregnancy is, who's eligible, who isn't, the appropriate investigations that we need beforehand, and also what we don't need, just to save on Medicare's dollar as well. Education resources to help if you want to become a prescriber so that you can confidently do so, and how to support your patients to access medical termination of pregnancy. So what is MTOP? So in Australia, we have a kind of a single medication that we use for it, MS2 step, which is a 2-pack of medication. The first medication, mifepristone, which we just kind of call step 1, blocks progesterone and causes the placenta to come away. And then a couple days later, so usually kind of 1.5 days sort of, the second medication, step 2, is taken, which causes the uterus to kind of expel the pregnancy. I always kind of describe the process as a little bit like we're causing a miscarriage. It's very similar. When I've had patients who have had a miscarriage, I've described it very similar. And these same medications are often given by hospital kind of early pregnancy assessment clinics to help pass a missed miscarriage. So it's taken, as I say, kind of step 1. We often might tee up for someone who's working during the week on a Thursday night. And then step 2 is taken 36 to 48 hours later. Usually we would, for someone doing a Thursday night, take that on a Saturday morning. They would have their miscarriage kind of Saturday midday. They've got the rest of the day to recover, Sunday to recover, and then are usually back to work on Monday. The benefit of, I guess, medical termination as well here is that it's quite flexible, so people can, do it during the work week if, for instance, they've got children in care during the week, or if they can, get grandparents. I usually say on the day of step 2, it's well worth having childcare. If you have other kids, your job on the day really is just to, chill out in bed or on the couch, not doing anything too strenuous, just so that people aren't kind of getting lightheaded and things like that. Usually between step 1 and step 2, there's no symptoms at all, and people can usually still go to work, go to school, whatever they're doing between that. And usually kind of after 15 minutes to 4 hours after step 2 is when things start. People have really varying experiences with it. Some people have a really easy time and say it wasn't even as bad as a period, and have kind of been concerned it hasn't worked when it has. But most people, I would say it's heavier than a period. Cramping kind of intensifies over about an hour, and then once the pregnancy products are passed, symptoms ease off a little bit. There might be some kind of heavy bleeding for about a week, and then that usually drops down to just spotting for another week or 2. There can potentially, like after step 2, be some nausea, vomiting, diarrhea, chills and fever. I'd say nausea and vomiting are the most common ones. I don't really see the other ones much, and it's usually fairly mild, but saying that, I do get all my patients to also have ondansetron, Panadine, and ibuprofen at the same time, just because I find it makes a significant difference to the symptoms. Complications are fairly rare. They kind of cite about 2 to 5% in the literature needing DNC for heavy or prolonged bleeding, often continuing pregnancy. I've never seen continuing pregnancy. It's incredibly rare. You don't necessarily have to go surgical if that happens. I've read about cases where people have just given another box of the medication, and it's worked second time around for whatever reason. Incomplete abortion, as you can see, is kind of the most common of the uncommon complications, and that would be if a bit of placenta or something had been left behind. Again, it doesn't necessarily mean you have to go off and have a DNC. We sometimes can just repeat step 2. Sometimes some doxycycline can help kind of stabilize the lining of the uterus a bit, or even if it's very mild symptoms, kind of expectant management, a bit like for some miscarriages, just waiting until the next period. Infection is quite rare, and as part of kind of the investigations that we do prior, I usually do a urine STI PCR just to rule out chlamydia and gonorrhea, and we can always treat that prior to giving the medication. Excessive bleeding, incredibly rare again. We generally do a follow-up couple of phone call consultations, and before step 1 is taken, a HCG level is taken, and then a week later we'll check it again and looking for really an 80% drop in the hormone levels to give us a bit of an indication that things have gone as planned. And those phone calls are really helpful to, I talk to people about what they experienced and kind of where they're bleeding and pain is at currently, which is really helpful to kind of get an idea of if someone's on a normal sort of trajectory or if they are just having a little bit more pain and bleeding than you might expect. And, if you're suspecting an incomplete abortion, it's helpful to kind of have that information early so you can try and put some other things into place and avoid a DNC. Who's eligible? So pregnancy is up to exactly 9 weeks. Some gynaes will prescribe later than that. I'm not too sure, but I think their cutoff might be 15 weeks or something like that. But for GPs, it's exactly 9 plus 0 weeks. If someone's tipped over to 9 plus 1, we unfortunately don't have the authority to prescribe. It must be an intrauterine pregnancy, which means that we need to confirm that on ultrasound as well. There are some practitioners in some sexual health clinics that do kind of very early medical abortion where they maybe aren't detecting that. I'm not too sure how they're prescribing it under the PDS. But yeah, most MTOP practitioners require an ultrasound to confirm that the pregnancy is intrauterine. I think I've got on the next one. Oh no, coming up. We'll go through the ultrasound requirements in a little bit more detail coming up. Contraindications, so who can't have a medical termination? If someone is seeking a medical termination and you pick up that they're not eligible, then referring for a surgical termination is probably the next best step, unless they are in that kind of period where they're just over 9 weeks, but they're still pretty keen on MTOP. Then if you can find a gynae who will prescribe for them, then that would be the next best option for that person. They do need to be for 14 days following step 1 within 2 hours of a major hospital. So if someone is going overseas next week, MTOP's not appropriate for them. I think there was a very, very rare case once where someone hopped on a plane overseas and had a major bleed. So they're pretty kind of cautious that you need to be within 2 hours of a hospital. That could deal with a complication. So for us, I always say to my patients, that doesn't mean you're stuck on the coast. You can still go, Newcastle, you can still go Sydney, as long as you're not driving out to Whoop Whoop and you're not hopping on a plane for 2 weeks and you're fine. If the pregnancy is not in the uterus or you suspect an ectopic, obviously this isn't a good idea and you can refer on. There's still, conservative management options with methotrexate and things if the patient's suitable. So it doesn't necessarily mean they need to go a surgical route either if avoiding that's important for them. Severe anemia, a lot of women are mildly anemic with iron deficiency. This is really kind of, if there's an HB under 100, then you would be cautious about doing a medical termination where, there's possibly longer bleeding than with a stop. If there's an IUD in, you can go ahead with an MTOP, but you would just remove it. Even if the patient has, a bicornate uterus and pregnancy is in one horn and the IUD is in the other, you need to remove it because the step 2 will cause contraction and we don't want to cause a perforation. You can leave an implant in though, so if the patient has an implant on, that doesn't have to be removed necessarily. Other stuff important to highlight here, the chronic adrenal failure. So the medication does impact on the metabolism of steroid. So if someone is dependent on steroids, particularly with chronic adrenal failure, or if they have particularly severe asthma and are very dependent on their steroid puffers, then MTOP's not appropriate for this person. Bleeding disorders, pretty obvious. Uncontrolled diabetes, I've done a lot of diabetics with this. It's really only if someone doesn't have, control of their sugars and isn't monitoring well, in case they have a bit of vomiting or diarrhea on the day and get disrupted there. Cardiovascular disease, I kind of put some caution. Apparently there's been some rare CVAs. To be fair, I've not kind of had someone with significant heart disease. It's usually just, controlled hypertension is fine. What investigations do we need? So there's quite a lot that we don't need, and I get a lot of patients referred to me from other GPs, and they come in with, their full antenatal bloods, their blood group and antibodies and everything. And if the patient is sure in their decision to terminate, we really don't need to be doing all this. In terms of pathology, we just need a hemoglobin to rule out that severe anemia. Beta HCG is helpful to decide when to scan, but also to compare future hormone levels. If we're at all concerned someone's having a bit of a miscarriage along the way and their levels aren't kind of going up, or if the scan is done a bit too early, the HCG is really helpful there. And then urine STI PCR, just so we can treat any chlamydia, gonorrhea prior to giving the termination meds and avoid a worse infection later on. We don't need the antenatal bloods. We don't need a blood group and antibody, even if someone is a negative blood group, because this is done so early in the pregnancy, they don't need to have anti-D. Imaging, just to confirm that the pregnancy is in an intrauterine location, and for accurate dates, if someone's not too sure of their dates, we do what we call kind of a pelvic ultrasound, but an early dating scan is what I write on it, which also helps patients when they're booking it, because a lot of radiology practitioners will try and book someone closer to 8 weeks for a dating scan. And really, we don't want to wait that long. We don't need to detect a heartbeat. We just need to see a gestational sac and yolk sac in the uterus, and then we can be confident that that's where the pregnancy is, and we can go ahead. You don't want to scan before we can see a gestational sac and yolk sac, because it's just not helpful. And some people do present very early at 4 or early 5 weeks pregnant. The scan shouldn't be done earlier than 5.5 weeks, or if you're doing an HCG and you get back a level that's 200, that's just way too early. Wait until the HCG is greater than 5,000 before scanning. If we scan too early, we just won't see a gestational sac, and the patient has to go through another scan a week or 2 later, which, for someone who's not continuing a pregnancy, scans are not a fun time. So we want to avoid them as much as possible. Patients.
There was a question there.
Oh, sorry,
so if someone presents at just over 4 weeks with a positive test and they're sure they want to terminate, so do they have to wait for that 5.5 weeks, or can they?
Yeah, if they can find a practitioner who will do a VMA, like the very early medical abortion, they may be able to access it early. But otherwise, we unfortunately for most GPs doing this will require that kind of confirmation that it's intrauterine. Similar for surgical, surgical termination providers usually won't see patients until at least 6 weeks for the same reason. They need to kind of do a scan prior to the surgery to make sure that the pregnancy is in the uterus.
Thank you.
No, that's okay. Sorry, I've got a bit of a frog. It used to be that you had to be certified to prescribe MS2 step with an online course, which I've got some information on coming up next. But in 2023, the requirement for certification of practitioners was dropped by the TGA. And this was done to hopefully kind of open up access to people. And it was kind of widely advertised in the media that this was changing, which was good in some ways, but in my experience, a little bit like, cannabis prescribing and stimulant prescribing, just because we can doesn't mean we all are. And it's still something that you need to have some education to be able to offer patients in a safe way. But unfortunately, some patients have now gotten the impression that all GPs are prescribing and they can just go and see anybody for this. And unfortunately, a woman I treated recently had gone to 3 separate clinics, thinking, that anyone could prescribe for her. They said they couldn't, and, sent her on. She went to a different one the next time. And when we've got a tight time frame of 9 weeks, patients hopping around to different practitioners is a really big waste of our time, and trying to squeeze scans in and get patients seen before that 9-week cutoff can be a bit stressful. And unfortunately, she just hadn't been pointed in the right direction at all. I've got some information coming up on where you can kind of, direct patients if you're not a prescriber but want to help them get access. But yeah, that was something that I kind of blame on all the advertising around it. That she really thought she could just go anywhere. How to, if you kind of want to start prescribing, get some education so you can do so with confidence. The MS Health, which is kind of the manufacturer of the medication associated with the Murray Stokes Foundation, they have an online training course which is completely free, takes 2 to 3 hours. This is the course that you used to have to do for certification, and you kind of have to repeat it every 3 years, and they update it with new information. Not that you have to do that anymore, but I still find it's a really good foundation. Family Planning New South Wales also have an online course, which is about 2 hours. That one's $160. It has some CPD kind of associated with it, with the RACGP, saying that you could complete the MS2 step training online yourself for CPD. The Central Coast Health Pathways also has a really detailed kind of formula on what to do to safely prescribe, what you need to order, and organising follow-up that I helped write. It is quite detailed, so I think for someone who's maybe just wanting to help their patient get access, it might be a bit too much. But if you are trying to help someone actually, do it yourselves, then I think that's really helpful. And then if you are really keen to get involved in this space, Children by Choice, which is a Queensland organisation, have every 3 years they do a conference, Reproductive Rights and Abortion Conference, which next year has just been kind of announced for September in Brisbane. I'll be going to that. I'm excited. But yeah, I think the first 2 options and the health pathways is really good for kind of adding in extra information, just to kind of get a bit of a foundation before you kind of have a crack. Helping your patients access MTOPs, so particularly if you're not a prescriber, but just wanting to, you have someone who comes in and says they're wanting a medical termination, what do you do? How do you help them? I would say getting them to a prescriber ASAP is so important. And I've had patients who have gone to really well-meaning GPs who have, ordered the bloods, ordered the ultrasound, but kind of had them wait until all these investigations were back before they were going to refer them on. And I would say refer ASAP. We often do our first appointment with these patients before all their results are back. If we have investigations, then fabulous. We sometimes do an all-in-one appointment and just get it all done on the day. But given what we need and the process and educating patients, the earlier we can see them, the better. and booking things in as well. You know, sometimes there's not availability the very next day. The New South Wales Pregnancy Choices helpline is really helpful. Everyone who is prescribing kind of should register with them so that they can be found easier, and they will, you know, help direct patients to local prescribers. The Gynecology Centres Australia in Gosford, a lot of GPs kind of tell their patients to go there. They only do surgical termination, so they're not an appropriate referral for someone who's wanting a medical option. Arranging investigations is super helpful. If someone comes in with these already, you know, we can get things happening a lot quicker for them. So doing your hemoglobin, beta HCG, and the urine STI PCR, and then ordering the pelvic ultrasound at the right time so someone doesn't have to have 2 scans. So from 5.5 weeks, or once the HCG is kind of over 5,000. Sometimes we can see things from the HCG of 2,500, but over 5,000 is a pretty safe bet. And then just to touch on contraception, in my kind of MTOP practice, you know, I have 2 phone calls afterwards with patients, and we talk about contraception as part of that. But some patients, you know, we kind of lose to follow up. They don't want to see us again, or they're more comfortable with their normal GP. And contraception, I think, is a really important part of the holistic care of medical termination. Saying that, I always tell patients I'm not the contraception police, and they're very welcome to do what they want to do. But we can quick start a lot of these kind of options pretty soon into the process. I've got all the details there, but saying that, to be honest, most patients will wait a couple of weeks until their bleeding has settled before starting contraception, which can be helpful to detect complications, you know, so that we have an accurate picture of what their bleeding pattern is doing before we add anything hormonal in that might change that. People can have fertility return, you know, as early as kind of 10 to 14 days following step 1. So it's always something that I talk about with them at every appointment. And I usually have kind of a bit of a 4-appointment process. So we usually have kind of a planning appointment where we organise everything that needs to be organised. The next one where we give them the medication and a plan, and then 2 follow-up phone calls afterwards, just to make sure everything's gone as we want it to. And that's me. So if anyone's got any questions, I'd love to answer them.
Thank you so much, Ebony. That was fantastic.
Yeah, thank you, Ebony. No, that was great. It was a great overview. And yeah, I think we've all got varying levels of confidence in this. And I find myself, you know, you might have a patient once every 6 months, so it's then you've got to read the guidelines again. So but it's great to have practical advice. Just one question from me. Like, what's your usual schedule structure? Do you sort of have a bit of a package of 3 consultations? Do you do a bit of, I don't know if it's too much of a personal question about private billing and bulk billing. What's your sort of schedule?
So I typically do it as a 2-appointment process in terms of kind of before we've given the medication, and 2 phone calls afterwards. If someone has really come with all their investigations and they are just, you know, primed and ready to go, then we'll do what we call an all-in-one, where we kind of squash the planning and actual kind of delivery appointment. Just there's no point bringing them back, you know, a day later to do when they're already ready. But yeah, so usually the first appointment I just kind of charge as a normal standard long appointment, just so that, you know, if someone is, most people that see us are pretty sure in their decision to terminate, but you get, you know, someone who is sometimes still weighing their options and wanting to kind of see what the options are and what it looks like. So at that first appointment, I go through everything with them. I make sure they're eligible, go through complications, order any investigations that haven't been done, and then we'll bring them back. And I'll kind of book the next appointment. We'll talk about kind of timing of how they might want to take the medication around work and things. And then at the second appointment, we'll bring them back. We'll sign our consent forms. We kind of have a really good relationship with a pharmacy that provides this for us. So we have the medication physically here at the second appointment. And so I'll open it up with them. We kind of talk about exactly how you take it. I'll give them a written plan. You're going to take step 1 at this time, 2 hours after dinner, and then you're going to take step 2 at this time. You're going to have your pain and nausea meds at this time. So people kind of come away with a really clear plan about what to do and what to expect. And then we've booked 2 follow-up phone calls. They've got their follow-up blood test as well. So I like that kind of, not everyone does the whole phone call thing, but I like to kind of have, maybe 4 days later, a quick little check-in just to make sure, they're not having drastic problems. And then between that one and the next phone call, they'll have, so the second phone call is about 2 weeks later from the medication. They'll have had their blood test. Bleeding should really be kind of settling right down, and then it's a good opportunity to pick up. Sometimes we see endometritis where someone will kind of have a bit of increased bleeding at that point, not heavy, but they just notice it has picked up a little bit. They might have a little bit of cramping. It's not super common, but it's a lot more common than retained products. And often at that appointment, I'll give them a script for Doxy, and we might just chat again next week. And all the ones I've kind of seen have gone, oh yeah, feeling so much better now. And then that's it. And I'm not currently accepting new patients unless it's kind of pregnancy care, because I do a lot of antenatal care as well. So by returning those patients back to their GP after those kind of phone calls, and once we've kind of closed the loop that, yep, seems like everything's gone as planned, you're feeling well, you're back to yourself. Yeah. Oh, and just in terms of cost, so the second appointment I do charge more for. So it's a 36 rebate. I charge 300 for that one, which covers all the kind of work we do, chasing results, ordering medication, as well as their follow-up. So we don't charge for the follow-up. So I want to remove any barriers to follow-up because I think that's a super important part of the process. So for most patients, including the medication, their out-of-pocket is under 300 for the whole process.
And do you use the non-directive pregnancy counselling item number sometimes in those? The 401?
No, I don't. I think I couldn't really. I didn't feel I could justify a 36 and that. I guess. So for me, it's just kind of easier just to keep it simple with the 36.
Yeah, fair enough. And sorry for hogging the questions, but you made a good point with you've got a good relationship with a pharmacist, because I know I had a patient that had to go to quite a few pharmacies, which can be quite a barrier.
Yeah.
Is there somewhere where we can look up which pharmacies do prescribe, or?
Yeah, there used to be through, if you kind of become like a certified prescriber with MS Health, there was a database, because it used to be that when GPs had to be certified, pharmacies had to be certified as well. So they kind of had to be a registered pharmacy, and it was a really awkward system still. You kind of had to search by each individual postcode, and so you had to do multiple searches to get like all your local pharmacies. It wasn't perfect, and I don't think it works anymore. These days, when I've had patients out of the area, and if I've had to get them the medication locally, I've just had to cold call pharmacies and say, do you get MS2 step? Can you order it in? And some of them want nothing to do with it at all. And some, have surprised you and they've just got a box on the shelf. But I do find access is really hard. And there was earlier this year quite a big stock shortage where there was a big recall of a lot of it, and trying to access the medication was really tricky. So I find that, if I try and help patients access it by kind of having, a pharmacy that's going to give it to them, that they know where to go, or physically ordering it and having it here, because I find it just adds an extra element of stress to the whole situation.
Can I ask a question just about the post management? Because I've been in the situation where I've seen patients after medical termination and have ongoing bleeding, and I'm always like, okay, where do I go with this? So just a question around what is the workup? Like, do we need to do bloods, ultrasound, etc.? And you mentioned Doxy. It's so I was wondering about that, because I probably in my head would have started Augmentin if I've ruled out STI. So just interested in are we thinking there's a low grade PID, or like where the Doxy?
I think that's the thought behind it. I don't know if it's necessarily in the guidelines at all, but I think there's kind of a Facebook group MTOP Docs Down Under, for, you know, a lot of prescribers are in that, and a lot of people have kind of mentioned that they've found Doxy helpful, and I never used to do it, and kind of went down the doing an ultrasound route, you know, for any increase in bleeding, and I've done a lot more Doxy probably in the last couple of months when I've noted that, and I found it incredibly effective. Patients who have had, you know, a little bit of increase in bleeding, a little bit of increased pain, and it has kind of just fit with that endometritis picture, then I've done it. Yeah, I'm not too sure about the like antibiotic choice over Augmentin. Maybe it's a bit better tolerated, but that's just what people have used and what I've used as well. But yeah, I guess if someone had, you know, a significant increase in bleeding, then of course you're going to go on and do an ultrasound, or if they're, you know, suddenly passing big clots. The bloods I do a week later, I repeat the hemoglobin, as well as the HCG, just so I can kind of track that a little bit. You don't see much of a drop typically in the hemoglobin, but again, it's kind of a good early marker that maybe things aren't going the way we expect.
And would there ever be role for any like vaginal swabs or like a repeat STI screen or anything like that, or would you just you just do either the empiric antibodies?
Yeah. No, I think I probably just haven't seen the value in that in anyone that I've seen. Maybe if you'd kind of seen a big change in discharge, you might, but yeah.
Cool.
I've just got another question. What is the dose and duration of Doxy that you use?
Yeah, so I've just used 100 twice a day for 7 days, just breakfast and dinner.
Thank you. And any other questions? Feel free to unmute and show your face if you like, or you could write in the chat box. Oh, here we go. We've got a question. Do you find you're doing a lot of weekend calls by initiating on a Thursday night?
No, I don't. In my early days, I used to actually physically give patients my mobile number and, you know, say, if you run into any issues, give me a call. But I found I only ever got one call, and it was from someone who was just kind of having normal amounts of pain that she was stressing about. And typically it just, you know, the process works, it's fine. And if I give patients like a really detailed idea of, you know, when to get help, you know, if you're having incredibly heavy bleeding. So if you're completely soaking 2 pads in an hour, 2 hours in a row. So, you know, you've flooded 4 pads in 2 hours. That's too much bleeding, go to hospital. They say fist-sized clots is the cutoff, which always gives me a bit of a giggle because I think half a fist would make me raise an eyebrow. But that's apparently the cutoff for what's normal. Or if someone's, you know, feeling very unwell, you know, lightheaded, fevers, chills. I know they mention fevers, chills as kind of a side effect, but if it's, you know, feeling, you know, not just kind of a little bit of a short-term thing, if it's hanging around for hours, then so I always kind of give people really detailed information on, you know, this is when I want you to go to hospital. And I guess because I usually, most people will accept it, I offer it to everyone on Dancertron and Panadeine, and really make sure they kind of taking that before step 2, so that it's at least kind of 10 minutes before step 2, along with Nurofen, because I've had some patients that while step 2 is kind of taken buccally, so it's 4 little tablets, you put 2 in each side and let them dissolve in your cheeks for 30 minutes. I've found patients even 10 minutes into that feel that things are kind of starting to get going. So I always want people pre-dosed so that the meds are already working for them. And I do see a really significant difference in the patients that accept that and don't accept it. You know, we've had some patients that, you know, want to be as natural as possible, and they have a rougher time.
Thank you. Yes, no, I like the tip of the Thursday night over the weekend, especially those that need to get on with working and getting on with their lives as well. So great tip. Any other questions? Yeah, lots of comments. So it was a great talk. Thank you. So no, thanks so much, Ebony. And I might use this opportunity to, oh, here we go, one more question. At what time do you order the follow-up blood test? What beta HCG is still acceptable?
Yeah.
And do you set yourself, and the other second part of that question would be, do you set yourself a reminder to follow up on that patient or a recall?
Yeah, we actually keep a spreadsheet because we do so many. We kind of, and I've got kind of one or two receptionists that it's sort of their job. Any calls that come in for termination, they take and they'll put a new patient in the spreadsheet for us. And it helps us kind of chase ultrasounds. It helps us kind of, we put in what date they're having their follow-up phone calls and things like that. So if someone's CNA'd, we kind of quickly notice it. And sometimes people, they just want nothing more to do with us again, and that's fine. That's their prerogative. But most patients will do a baseline HCG has to be done for 72 hours before step one. I'll usually do it on the day of the appointment because usually we're seeing them the day or the day before they're planning to take step one. Or if they're going to take it a bit later, I've seen patients where they could only get in on a Tuesday and they're going to take step one on a Saturday. I'll give them a takeaway blood form and say, do this Friday or Saturday beforehand. So you want to do 72 hours before step one, you want your baseline HCG. And then 7 days after step one, you do your follow-up. When I'm doing a lot of them, I do kind of do a Thursday night sort of thing. I'll say do it from Friday morning, the following Friday. But it can be done later than that. It doesn't have to be straight away as long as it's not done too early. We're looking for an 80% drop in that HCG, so from the baseline down to the week following. In reality, we see mostly a lot higher than that. So we'll usually be kind of 90 to 95% drop, but 80 is the cutoff.
And do you need to follow that through to zero, or is that no, you can just do that one off and go, it's
we just do that one off and can be pretty reassured from that.
Okay.
I will kind of like at the phone calls afterwards tell patients, there is still some HCG in your system. If you do a pregnancy test, it's still going to come up positive. And that can hang around sometimes just very slightly after their next period as well, depending on how high their levels were when they came in. But yeah, I typically don't follow it up. I go on symptoms.
Great, thank you. I was always told by an obstetrician, under 25 is reassuring, but but that was in terms of then you're unlikely to have an ectopic or anything like that. But
no, I see a lot higher than 25 and ignore
it. All good. Thank you.
Ebony, I've got a question.
Yeah.
I'm reassured by the thought of doing a follow-up phone call, but do you have any routine advice for people who live by themselves? Do you suggest that they have someone check on them or be with them or something like that?
Yeah, I do. I strongly encourage an adult support person on the day of step two. And if someone, can't get a friend or someone, then I say, make sure someone's aware of what's happening, touch base with them, during the day. I've only kind of had one person who on the day, really needed help. She was a single mum, and despite, my advice to try and get some help and do it on a day where the kids were in care, she was up and about looking after 3 kids all day and had a faint by herself, which, was not great. So I tell people that story to try and, help them realize, why we want that extra care around and to encourage them to really on the day just be resting. And if people are doing it on a school day, we will get them to take the medication once they're home after school drop off, and I've had patients who again have ignored that advice, and someone took step 2 and then went out to the fruit and veg shop and was like, oh, that was a bad idea. I'm like, yes, it was a bad idea. Yeah. So
yes,
yeah,
good.
I try and make sure they understand what they're in for, but people are people. They're always going to do the right thing.
So it's good to know what you recommend. That's the stuff. Yeah. Thanks. That was great.
Thank you.
Great. Thank you. Thanks again, Emily. And before I hand over to Sandy, I just wanted to take the opportunity to plug our session in 2 weeks' time, which